From the lab that made surgery safer worldwide, Ariadne Labs, come two builders of better care, Dr. Asaf Bitton and Dr. Bruce Finke. They've led federal models, redesigned primary care, and are proving that relationship-centered medicine can scale.
We've deluded ourselves that we can produce health by building beautiful glassy hospitals, by optimizing 340B and length of stay. You've already lost the game.
What should we be doing to actually make a difference in this space?
Yeah. We were talking about incentives as money, and what Asaf's talking about is a different kind of incentive. What primary care folks want is that time and space for that relationship, and that's what patients tell us also.
The part of your healthcare system that could most be leveraged to fix the super expensive, broken acute care system is being burned out and dissipated and seen as basically a charity case worthy of 4% of the healthcare dollar.
I'm Judson Howe. I lead hospitals. I've seen a lot of what's broken in healthcare, but we're going to find out ways to make this better. This is Healthcare Reframed.
Fascinates me in the medical hierarchy that there are these elite physicians that go into IM and FM, not because they don't have other options, but because that's where they want to serve. And I don't want this. Catherine and I turned into an infomercial last night about FM, and then it was totally fine.
You have the FM,
but it's not my
but this is a really important conversation. And when we think about workforce, both pipeline and burnout, inflow, outflow, what deconstructing and understanding. Why do people make an economically irrational choice? Mm-hmm. Why do they make a socially irrational choice?
It's like what you said. It's not really a sacrifice.
That's right. And I agree and disagree. It is like putting it on the table. Lifetime earnings. We both left millions of dollars on the table. We left, going on certain subspecialty hierarchy, prestige stuff. Right. If that's important to you.
Yeah.
So the question is. I think for many of us what did we give up? But why was it such a natural choice to sort of give that up? And why is there this kind of strange hierarchy that there is something to give up in the first place to do the right thing to serve?
Why does that decision even exist? And why does Yale nor Harvard even have family medicine as a rotation?
So a lot of work done over the last 20 years around waste in the system, right? And a lot of efficiency work. And in general, the redesign of care, the redesign of primary care has been efficiency focused. One could argue that the greatest waste in the system is in the relationship between the clinician and the patient.
Okay.
And that's where we leave stuff on the table. That's where when we don't allow people who go into primary care to engage with patients the way in the way that they wanted to, in the way that drew them into primary care, then we're actually wasting a huge amount of resource. Right? But it's not you can't quantify it in dollars and cents in quite the same way.
The value of primary care is mediated by relationships that are meaningful, that are substantial, that have offshoots of things that we want to foment, like trust, like engagement, like health behavior change. But the unit of intermediation, the unit of transfer of that value is the relationship. So the very thing that at population level studies, having more primary care in a given county is associated with less mortality, controlling for everything. That is a true statement.
Is it also associated with lower cost as well?
That we should talk about that. It's not clear because there are a lot of probably over decades, but not over years, and that's worth a whole conversation. But if you put the same study number of specialists, pick any specialty, number of ERs, number of hospitals in a county density per 100,000, not good things to have, but not associated with mortality benefits. Primary care is driving that mortality benefit because of this relationship mediation. And yet the thing that is so valuable is the thing under pressure. The time, the space, the mental awareness, the ability to gather a team of clinicians and a principal clinician to be in relationship with that person and walk with them, accompany them over a lifetime. And that is worth way more than the 3.5% that we spend of the total healthcare dollar on primary care. So when Bruce talks about waste, we're wasting the very thing because we thought we could, in the last 15 years, dress it up as, well, the problem with primary care is it's not efficient enough. They need to do team-based care and they use the EHR and just run cycle times and processes faster and better. But primary care is not a hospital. Primary care is a series of relationships that over time create health inside the walls of the clinic and outside the walls of the clinic. And that's the kind of opportunities case, we can talk more about it, but that's the opportunity case we're dealing with.
How do you scale that, right? Because I think there's been, and in you two here with CMMI and Ariadne, right? Imagine it goes in there just a little bit. And yet we've seen these different initiatives, right? These care-based models, these patient-centered medical homes, and I'm really probably very limited on what all these initiatives have been. And yet it feels like we're going the wrong direction. Like, why do you think these things have not taken off at scale?
There's not a single thing that's going to make it happen. There's a payment context, sort of changing from the dysfunctional visit-based payment that I'm sure you've talked about in a number of your conversations.
A little bit, yeah.
And to a population-based payment. That's like a contextual factor. The efficiencies we've talked about that we've worked on for 20 years, that's all important work.
Yeah.
And that's all to enable the relationship. But at some point, we have to look at making space for that relationship. We have to prioritize space and time for that relationship. So thinking about the system at CMMI, and Asaf and I worked for...
What does CMMI stand for?
The Innovation Center at CMS. Okay. So that was started as part of the Affordable Care Act. Did a number of very large, the kind of scale you can only get in federal government, sort of primary care tests of payment change leading to care delivery change. And all of that is working from the outside in to kind of create the context for stronger relationships, the kind of relationships that Asaf talks about, the relationships that lead to better outcomes. At some point, we have to start to look from the inside of that relationship and say, how do we create space? Whether that's time, that's more about what we expect to come out of that. It's both about the time to have the conversation and what we expect to come out of the conversation. What are the patients looking for?
Give me an example of where this is actually working well, or where you've actually received some hope that something could actually...
So I'll give you an example that is not one that I think is scalable.
Okay.
Or that we want to scale, in part because of the equity considerations, but concierge medicine.
I've been hearing about direct primary care.
Direct primary care, right? What do? They create the context in which there's time for the relationship. And people who have the money can pay for that time and that relationship. And they value it enough to pay for it.
Yeah. Why couldn't that be equitable? Is there a mechanism we could make that equitable?
Well, right now it's based on individuals' ability to pay, and these are individuals'
A monthly fee,
and people can barely pay their premiums.
But why couldn't a community organization or
the government or a payer?
Yeah.
I mean, so this is the logic of. If we step back for 1 second, well, what I think the thesis is that we've been asking the wrong questions about what's the matter in large parts of our healthcare system. So we've been asking, as Bruce said, a series of questions about efficiency. Good questions. We need to think about how to make our systems more efficient.
Like I'm hearing link waste to efficiency.
Yeah. Waste to efficiency. We want production cycles that actually produce access and produce safe care. This is all important. Mm-hmm. But the challenge and where we need a frame shift in the right questions around missing the value of primary care is that primary care doesn't fit into an easy management induced kind of, Taylorism, the sort of management theories from the 40s and 50s. We're not making widgets here. And in fact, even worse, the payment model, which is an idiosyncratic just accident of how things came to be, has essentially said primary care in the US is about churning the number of visits. That's pretty much the lever that you have to induce access and revenue. So you live within those really narrow quadrants, even though the right question to ask is, what does every successful health system in the world have at its core? And that is a strong primary healthcare base. And we can talk about the differences between primary care and primary healthcare. But if that's the case, and I still haven't found a counterexample, show me a high-performing, efficient, effective, respectful, high-outcome system that serves a community. It always has a strong primary care base. So in the US, the issue has been we have a production model that's based on visits and money that isn't attuned to the ways in which primary care in all of these communities, including in the US, produce good care. So part of the issue is, how do you create the space and the time for clinicians to have meaningful relationships? As more can and should be done in primary care, we've expanded from a few quality measures to hundreds of quality measures. We have chronic disease treatments that expand widely. You need a team that's connected by IT, a team that isn't just playing on a visit calendar of 20 or 15-minute visits, to be able to proactively, preemptively reach out to a population. It's able to deal with their acute needs, and it's able to not just do acute and chronic, but also the other parts of good care, which are palliative, which are rehabilitative, which are promotive. Those start to then get into kind of a function of a primary healthcare system, where it's not just about visits for outpatients, chronic diseases, but it's really about the core functions of primary care: first contact access, comprehensiveness, coordination, continuity, but also the ability of the medical system at its edge, which is primary care, to reach out to communities and to reach out to other segments of society to create health in the community. So that interplay between public health and medicine is often interlaid through primary care.
I think my concern, and again, I was an executive on what I joke is, not going to joke, is the fraying edges of the American system.
Yeah.
So like in my market, we were short by 45 primary care physicians for a couple 100,000 people. And there was no recruiting strategy that we discovered that was really going to address that. And by 2022, we were spending $330,000 for a new grad coming out of residency, and that still wasn't enough to close that gap. And it almost feels like we're going the wrong direction from a workforce development perspective.
We are.
Assuming what you're saying is true, which is if we want to make a dent in the American healthcare system, we're going to have to figure out how to incentivize primary care in a very different way.
I think incentivize, but and when we talk about incentivization,
I heard you talking about incentive models.
Well, there's payment models.
Okay.
Not the same as incentive models.
Tell me. I got to stop. What is the difference?
So incentive models assume, I'm assuming you're using incentive in terms of dollars and cents.
I was.
Right. But we know from Deming's work that actually those kinds of incentives actually often undermine performance. They undermine the intrinsic motivation that leads folks into the work and leads folks to want to excel at the work.
Okay.
It's not to say that folks don't want to be compensated well, but if we rely entirely on compensation, we'll drive salaries up, and that'll be good. No complaints.
And that is happening.
And that's happening. That's not. But if those clinicians, and here I'd say physicians, nurse practitioners, PAs, because increasingly we're not talking about a primary care workforce that's physicians. We're really talking about a primary care workforce with physicians, nurse practitioners, and PAs. And that if they're still caught in a delivery system model that constrains their ability to talk to the person in front of them and understand them and know who they are and provide care out of that knowing with a sense of sort of mutuality, a sense of shared purpose, they'll take the money. But when they're done they'll take the money and work less, which we see, because no one can actually manage to work a full-time.
Yeah.
It's very difficult to work a full-time job as a primary care.
I had a doc calculate it recently that said to do all the things that you asked me to do, it's 27 hours a day.
Correct.
Yeah.
There are famous series of studies.
Does that sound about right?
Well, it sounds right, and I think it is right. In fact, it's only grown. Like there are BU studies in about a decade ago, and they've just been redone. If a primary care physician, PA, NP, did everything that was on the recommended list for acute and chronic conditions, and preventive conditions, they would have to work 365 days a year at 27 hours a day. And that doesn't even count the acute care, like just people showing up with like a knee contusion or pneumonia or stuff.
I'll tell you what folks are doing, primary care folks are doing with the increased
What are they
money.
Yeah.
They're buying down their time. They're working 70%, 60%, 40%, and they're spending extra time at home charting, documenting, looking things up, so that when they go see the patient, they know what they're doing and can give the patient 100% of the care that they want to give.
Yes.
So they're using the extra dollars, but not the way we think that they are.
But aren't we also seeing, and we don't have to put data to this one, but are we emotionally also seeing physicians become almost more like script writers, referring to specialists more quickly without the extended practice of medicine?
I think that's one of the
more diagnostics.
I think that's one of the ways in which this kind of dystopia of when you have the sort of the tyranny of the hamster wheel, and you're on this hamster wheel trying to do an impossible number of things in a short visit. Some people go I'll take down my time so that I can prepare and spend more time with patients, or et cetera. Some people go the script and refer. And remember, as the pipeline reduces or the outflow increases in terms of workforce, it only then costs the people staying. Panels are growing because the people need the care.
How big are they getting right now?
Well, I mean, I can say in our system where we practice in teams, the FTE panel size is about 2,600 people.
Okay, and that's up from what?
A few years ago, before team-based care, it was, we had people with panels, again, per FTE, 1,500, 1,800. Now, you should be able to take care of more people with, a team. But, we did a study with just Medicare beneficiaries. The average PCP, just for their 15 or 20% Medicare beneficiaries in their panel, interacts with over 150 specialists. That's just for Medicare. Maybe it's 200.
150 specialists, different specialties for different people.
Different people and specialties. So you think about the sort of cognitive load you're asking people, when every chart for your patients is CC'd to you, for every specialty visit, when every hospitalization, when you have to track their chronic disease and their preventive it becomes a massive information chaos that is alone not tenable. And so what you see people doing, which is a rational decision, is say, pay me more, yes, but they want to use the money to build teams to help share the care. What you're seeing is people taking down their time so that they don't practice as much, so they can do more, or taking down their practice panels, which is direct primary care, which is that membership model, or a version of it, which is concierge, where, people, and we know folks here, used to have a panel of 2,000 patients. They say, I'm tired. I want to take care of 300 people because I know how to be their doctor. To make the economics work, I want off the treadmill, so I'm going to charge whoever can pay $5,000, $10,000. It goes up to, I've seen $50,000 a year. Now, people do that because they want to practice in a way that they went into primary care. Again, this relationship-focused time, the ability to sit and be with a person, not to waste time, but to figure out, yes, they might have come in for belly pain, but what's behind that? Is it an abdominal organ dysfunction, or are they depressed, or are they abused, or what's the story? It all takes time. And I think this is the universe. This is sort of looking from the hourglass of primary care outwards, all of healthcare. Healthcare workers want time. They want time with their patients, and the system has become so chaotic and complex that it depersonalizes the relationship because there's such a constraint on time.
Yeah.
And so much of the work that we've done in trying to build payment models for primary care it's to build the space for relationship to happen, or the work at Ariadne, you build communication models, or you build sort of palliative care models that allow people to recenter and get back into, why did I go into sort of this healing profession all together? I didn't come in to sort of just do paperwork and to be a typist, like while we're sitting in a chart doing that, or to move messages around late at night, or to see 40 people in an ER, or to do 10 surgeries in a day. I, as a healthcare worker, nurse, doctor, whatever, came in to, if you're a spiritual person, to enter a sacred space between people, where people come to you at their most vulnerable or at their most needy, and you say, I'm not here to fix you. I'm not even here to help you. I'm here to serve you. I'm here to walk with you. This is a frame from a mentor of mine, Rachel Naomi Remond. She said, a true healer isn't here to sort of, if I say I'm here to fix you, then I assume you're broken. If I say I'm here to help you, then I assume that I'm better than you. But if I'm here to serve you, we're going to walk together, figure this out.
Yeah.
That's what people want in healthcare.
So that resonates with me, Asaf, but I've also heard, the classic specialist, let's take ADP, say, enough of the kumbaya medicine.
Yeah.
What would you say to a colleague specialist that said, enough?
Listen,
You guys have become too eccentric.
No, listen, I would say that when I, send somebody with a dangerous arrhythmia, to an electrophysiologist, I want them to be locked in, technically astute, respectful of the patient, how scared they probably are, and do a dang good procedure to hopefully fix that issue. And same with many of our procedural colleagues. And that's what patients say. Send me to a colonoscopist and she'll do the best job for that issue. But so much of medicine, and so much of, if you look at the patient experience surveys and why people are so pissed off, they know that in the technical procedural brokering, or when they're in the ICU, they want safety, respect, technical proficiency, and get out of there as fast as possible.
Yeah.
But in the rest of medicine and healthcare, they want to be seen, they want to be known, they want someone to walk with them, to give them choices, to help them make a choice that's aligned with who they are. And I push back ferociously to any of our colleagues who say, well, that's soft stuff. I say, your hard stuff and soft stuff, you're asking the wrong questions, my friends. Your reason why, we know this from surgery literature, work that some of our surgical teams did. You can predict the risk of surgical errors by putting a camera on a preoperative patient visit and measuring the communication quality of that conversation. Okay. You could even predict the risk of a surgical error or malpractice if you turn the volume off on the camera, and just by the quality of observable non-visit based communication, eye contact, listening, who talks, length of conversation, you can predict that on the basis of communication. So when people say, not that you were saying, but when people say, that's soft stuff, but I'm interested in the real stuff, they actually need to look at the reality of the literature a bit more.
And you were talking about incentives, and that sort of we started this stream of conversation with incentives, and money, we were talking about incentives as money, and what Asaf's talking about is a different kind of incentive. So if we want to increase access to primary, we want to increase the pipeline into primary care and decrease the outflow from people who retire early, give up, cut back because they can't manage a full-time schedule. What primary care folks want is that time and space for that relationship. And that's what patients tell us also. Yeah. So in that way, we're aligned.
Yeah. So you mentioned Deming earlier, right? Which I think his classic line was, every system is designed to get exactly what it gets, right? So is that the general gist?
Yeah.
But and so I guess we're getting it. we're getting what we've
We have
designed.
the system. That's right.
And I think in healthcare, you know, I've heard this throughout my entire time in healthcare, which is we can't fix it. We've tried that before. And so I think of somebody like Danella Meadows, you know, and she talks about these leverage points in systems. So I can't imagine two better people to ask who helped, you know, lead CMMI or Ariadne. Like, what are those leverage points in this big system as the problem broadly defined we just went through? What should we be doing to actually make a difference in this space?
Yeah. So I'll start, and then I want to, you know, we've talked about the fact that there's been a lot of work around both efficiency, development of care teams, and a lot of the sort of that piece of work is captured beautifully in the National Academy of Science and Medicine report on primary care.
Okay.
That Asaf was involved in that a few years ago. That it really captures that work. That work is really important. That efficiency at a system level, that's like critical. Again, that enables the relationship. We probably need to look at the problem additionally from a different direction. Because whenever you run out of solutions, it's time to turn the problem around a little bit. Reframe it. Exactly. And one of the ways to reframe it is to look from the relationship out.
Okay.
So the question is...
You're saying from inside.
From inside the relationship.
And potentially also from the outside in, but we've started to do that.
We've got a lot of outside in the work a lot of folks have done around thinking about whole health, whole person care, in the work that patients have done, people and that patient advocacy community has done to say, what is it that patients want, what people want in care, to look at redesign from that perspective out. And that's a critical leverage point. And it's about creating time and sort of mental space.
Great time.
For relationship.
What is mental space?
Mental space means that you're not as much worried about, are you applying the right diagnosis for a code, as are you naming the condition in a way that helps the patient move forward.
Okay.
Are you able to sit down? So there's two ways to walk into an exam room. You can open the door and say, so I heard you're having some problems with your knee.
Kind of like you were saying earlier, there's a problem with you, and I've heard about it.
And also,
organ or disease
we're going to narrow the conversation right away. You signal to the patient, we're narrowing the conversation down to a problem. We're going to solve that problem, and then you're going to head out the door, and I'm going to go on to the next one.
And this is biomedical science.
Or you can walk into the room and say, I'm Dr. Finke, Bruce Finke. It's really good to meet you. You know, what brought you in today? And that's just one way of doing it. I've been working a lot with folks with dementia, with Alzheimer's, and it's striking the degree to which walking in, talking to the person who's living with dementia, introducing myself.
The person experiencing it, or
the person who's living with it, who's experiencing it. They're both living with it, but often talking to the person who's living with dementia, introducing myself, looking at them, having them look at me, and then having them introduce the person with them and start the conversation that way, opens up. That right away makes it a different conversation. So that's about opening up space and communicating that this conversation is something more than about addressing a set of problems. It's about addressing you and what you need. And that's another leverage point.
Yeah. What are your thoughts on
so much, I can almost sense a little bit that, like, from an executive or financial perspective, it can be hard, or maybe hard for some of the listeners to sort of be like, these primary care folks, they're talking about nice things, but I'm bottom line. I'm trying to make next Tuesday.
340B cuts coming in January. I've got work requirements. I've got a budget to close this.
Totally. Yeah. And I have patients to see next week, and I have messages that are building in my inbox right now, and a public health and healthcare improvement organization that, is waiting for us to come back. And we can play the game. We can play the game of, I can make your inbox more efficient. I can get your 340B waiver done a little faster. I can get your length of stay 0.2 days down. I can even maybe dip your toes in the water of value-based care.
Hire. Come do it.
Right. So we're nibbling on the edges. If we're having a conversation, as I think we are, and I think we need to, about reframing healthcare, rethinking it, I'm not interested in nibbling. I'm not interested in what high-paid consultants can tell you. That's the easy stuff.
Yeah.
I'm interested in asking the biggest questions. So it's trite to say we basically built a sick care system, not a healthcare system. That's true.
Why is that trite?
Because that we need to pull that string and what do we actually mean? Well, what we mean is that every time we try to have a conversation on the fundamentals, on what we're willing to spend $5.2 trillion as a society on, you get so far into this conversation and say, but then you guys are talking about things that are just squishy or, too impossible or, and we can just label it as we're good at sick care and we're not good at healthcare. Mm-hmm. And I would say, okay, but that's just the start of the conversation. The conversation goes like this. We're actually not that different from every other OECD country. We're all willing to spend the same combined amount on health and social care.
Okay.
The difference between us and France and us in the UK or whatever OECD you want is that they spend 2/3 of that health and social budget on social care, social welfare, the dementia supports, the sort of better food in the community, environmental stuff, and then 1/3 on healthcare. We've deluded ourselves that we can produce health by building beautiful glassy hospitals, by optimizing 340B and length of stay. You've already lost the game. When we get to you in the hospital, we've already lost the health promotion and population game because you can only nibble at the edges. It's really important to have acute care hospitals and specialists who technically do really good technical things. But I hear you asking, how is it that we're spending $5.5 trillion and have a life expectancy that's falling and we're 38 out of 38 on OECD, and we can go on and on. And then anytime someone says, well, we need to just change the frame of the conversation, we're told, but we have to deal with, either we reframe the conversation around there's an imbalance between what we're willing to build and do. And right now we're willing to build and do acute care systems that work on acute care payment and outpatient systems that work on historically accidental payment frames that induce absurd behavior, bad outcomes for patients and populations, and a burned out workforce, such that the part of your healthcare system that could most be leveraged to fix the super expensive, broken acute care system is being burned out and dissipated and seen as basically a charity case worthy of 4% of the healthcare dollar. And instead, we're trying to fix healthcare from the rubric of the expensive monolith of acute care healthcare systems that know one thing: how to fill beds, fill ORs, fill EP suites, fill colonoscopy suites. And I think what we're saying is the real reframe is to invert the pyramid. You want a good healthcare system, you spend more on primary healthcare, you spend more outside of the clinic and the walls of the hospital, but that requires, yes, you to solve what you do next Tuesday with your acute care system, but it requires the decentralization of the primacy of acute care and specialty care in the US. And nobody wants to talk about that because, don't get into the specialty primary care wars. But we have to actually have that discussion because the US becomes the US healthcare system when we can spend the type of money that allows the kind of money flow into specialty care and then sees primary care as a charity.
So I mentioned Danella Meadows, and she wrote a lot about systems thinking, and the thing that impacted me the most was her leverage points. But I think you just called it out, which is we can spend all of our time on the lower leverage points, the parameters of healthcare, which is where people like myself, CFOs, recovering from CFOs, we're tinkering with the parameters. We're changing the valve flows.
Right.
Yeah.
And I hear what you're saying is change the goals of the system.
Correct.
Or challenge the
We're
paradigm.
playing the wrong game.
And we've seen that tested actually from the CMS Innovation Center, right? Their models, the Maryland model,
Yep.
put a cap on Medicare spend.
Yeah.
And then increased spend in primary care through the Maryland primary care model. And then there's an entity within Maryland that sets rates and sort of within the cap on Medicare spend figures out how to distribute that cap.
Yeah, and redistribute.
And redistribute
That's the word. Redistribute our focus, money, time, and what we privilege and what we hold high.
Yeah.
And unless you get into this redistribution game, and you go to a doctor's meeting, and the big thing to not say is redistribution.
Well, I was gonna say, like, Biden intentionally used the term pre-investment, right? Because that word is so heavy.
You see this in the Medicare fee schedule, which is like the fee schedule that most other payers then use on paying codes. And this year, there's what's called an efficiency adjustment. For the first time ever, Medicare is proposing to take these mainly technical procedural codes and put a 2.5% reduction on their value year by year, but not put that reduction on primary care codes. And you would think from some of the discussion in the specialties that this essential redistribution is like the end of the world as we know it. And yet, and I understand people will fight for their cheese and they'll fight for their own interests, but we as a healthcare community, and there are so many thought leaders who, they sit around and they tell you it's just all about, rebalancing the deck chairs on a sinking ship. No, we need a new ship. And unless you figure out how to jump to that new ship, we're just all kind of quietly going down.
So that's a really good point, because are we trying to steer this ship, or do we truly build a new canoe? Maybe start with a canoe.
We're building it while we're steering it. I mean, the fact is, there's
Is this a catamaran then? Is this what we're
I don't know what it is what the right analogy, but Asaf and I have been in a number of discussions, and almost always someone says, we just need to start over.
Yeah.
What would that?
You don't.
That's the Doge
Right.
mentality.
You don't.
Yeah, and
don't start over.
that's the VC mentality of great startup companies that, in primary care, we don't need to name them, but there have been a bunch of great startups. Their famous founders have said, it's time to just blow up the system.
Okay.
We'll get a new fund flow. We'll get the money and we'll do it a different way. And you can create great innovation insights from that, but not at scale.
Yeah.
So you actually have to fix the shit.
You have to fix it while you're in it.
Yeah.
That's what we're doing.
Okay.
So it's not a small change, it's a big change, but it happens a piece at a time.
Yeah.
But I don't feel. Well, maybe I do feel. We've been talking about this for 40 years, right? We talk about, the Dartmouth Atlas came out, 40 years ago, 35 years ago?
35.
Talking about care variation, price variation. We're worse now than we were in the 90s.
Right.
When, I'm forgetting the professor's name right now. Jeff, this doesn't matter, right? We'll skip that.
Yeah, Elliot Fisher does.
Westberg.
That was Elliot's call. Yeah. So where, and I did Andrew Elliot, you spent your entire career on this, and yet we've moved backwards. So how do we, in our moral responsibility as leaders in healthcare today, make sure that in 5 years we can look back and say something's better?
We do that by learning from what we're doing, from what we've done. So one thing we've talked about is the drive for efficiency, the drive to actually pull cost out, if you will, of primary care, or make primary care do more for the same dollar.
Why don't we put more cost into health primary care?
Right. Well, the drive over the last 25 years has not been to put more money in, right? It's been to make care more efficient and ask primary care to do more.
Right.
Without
for
putting
every dollar input, primary care is the only part of an improvement system that's been asked to show an nearly immediate ROI on the new dollars in.
So
never does that happen for the new PET scanner or the new oncology suite.
So that's what
You know that from your.
Yeah, that's what we've been doing, right? And what's it led to? It's led to a degradation of the workforce, not the quality of the workforce, but the numbers.
Yeah.
Fewer folks coming in, more people leaving or cutting back time. That's a 25-year experience. So we can say, well, we failed. Well, we can say we learned.
What did we learn?
And what we should have learned, what we need to learn.
And what we did learn.
Yeah, is that that kind of efficiency, while important, isn't enough. That one has to value what happens in primary care. That has to have a value in the system. If you start with the place that says primary care is the essential part of our system, this gets into geriatrics again, right? Where do most older folks get their care? They get their care in primary care.
Yeah.
We're not going to improve geriatric care in America through more geriatricians. Geriatricians have an incredible and important role to play. We're going to improve geriatric care in the United States when primary care has the ability to provide better geriatric care, right? That's where, so we have to start with the assumption that the solution is through primary care. And then we start to sort of think about the design from that perspective.
So your field is geriatrics, right? But you could say that for almost the entire continuum. Should it? But yet HMOs made primary care the gatekeepers.
Right.
And that's almost part of why we got
They made some central errors. That primary care would become gatekeeper, barrier, border guard, cost control center. By the way, the UK made the same mistake when they said, they saw the logic. They said, we'll give primary care trusts, these primary care, little ACOs, essentially all the money, and they can dole it out. So then they neither had the financial wherewithal nor the sort of hustle and bustle to sort of, throw elbows and be in charge of their other specialty colleagues. The point is, as Bruce said, so I want to challenge one thing. So a learning frame asks us to ask questions about what we know and how we know it. And if we do that around primary care, which I think we're making the argument is one of the central leverage points to change all of healthcare, primary care as a way of doing healthcare, as a focus of and site of healthcare, as a sort of rejection of sick care, transactional, factory-based, in and out, expensive, error-filled care. What we have learned in the last 10 years has not been abject failure. And while the workforce issues in primary care are getting worse, what we are learning is that when you start by reframing the business model, the business model is not about a unit of service that's paid for by visit, but rather needs to move to a risk-adjusted amount per person to be paid to primary care prospectively to take care of that person and their needs over a year. And that shift toward this kind of hybrid and prospective payment is actually happening. When we started some of the work as senior advisors at the CMS Innovation Center, we asked a fundamental question, which is, well, can Medicare, capitate or partially capitate primary care?
Did they do it?
And the answer was, well, it can't be done.
That was the rote answer.
It was the rote answer. So we said, well, where is it in statute? Like in the original statute? Long story short, a year or two into this conversation, it turns out it's not that it's in law or needs an act of Congress or anything. It's just it hadn't been done, and there's some important and kind of time-consuming reprogramming of the claims that need claims-based system, which is retrospective, that needs to be done. But by the model that we both worked on called the Comprehensive Primary Care Plus model, so for the first time, capitating part for practices that were ready to receive, they were receiving Medicare partially capitated payments to care for those patients over a year. And then in the next model, primary care first, it's a fully capitated model. So what was just undreamable and can't happen, and there's probably a statute, is now possible. Now, did those models, were they the home run and allowed CMMI to scale through the legislation? No, they didn't meet their... Well, part of it is that the frame of the task at hand as written in the ACA, it was understood that a scalable model is one that both improves outcomes and at the same time decreases costs.
Do both
You have to do both.
to qualify for this classification.
And the designation is that if they do that, then the actuary certifies them, they take it to the head of CMS, the secretary of HHS, and he or she, without consulting Congress, can just say, this is a model that all beneficiaries in Medicare should have. And then by virtue, other payers will follow. So let's get back to our earlier question, which is meaningful third-party evaluation, statistically significant outcome improvement, plus cost reduction within a couple of years, both a realistic target and the right target for a field that's essentially been parched as a desert in terms of resources? You put in a little bit of drip irrigation and you want in a year a bumper crop? I mean, I'm asking it reflexively, but I think where
I
we're
kind of
going.
want to say yes. I mean, why not right away? I mean,
Why not? Because these are teams, as Bruce was saying, that were operating. I mean, when the first model that we built together with colleagues, less than half of the clinics had a working budget annually that they could show us so that we could understand, how will you use these new payments? Is it, do you have a budget? And only half of them said that they did.
Also, some of the changes that happen that this kind of care allows to happen, that it takes time. You see, if someone stops smoking now, you don't necessarily save money in the next year, right?
okay.
You save money over the next decade, 2 decades, 3 decades.
Okay. Yeah.
So part of it is time frame. Primary care is a long game.
Right.
It's about investing in the individual. It's about valuing the individual in front of you, investing in them,
Yeah.
and investing in the relationship that you have with them, so that they can live the best life, the life that they want to live.
Yeah.
And that pays off. That can pay off for a health system over time. And when we see, mortality rates in the U.S. increasing, when we see life expectancy decreasing, that's a failure of our system over time. That's not a single. There's not a single point of
So
failure.
I'm almost hearing to say, like, we're putting too much on primary care. Like, primary care is a powerful leverage point to reduce.
But it's over
But
time.
you have to give it. You have to.
But we're asking you to fix the churches and the community structures and the social groups and the
And
neighborhoods.
the broken workforce and the
Society is, we're going to use
Right.
primary care to fix society
so and that's a hard problem.
when health is a society.
And that's what Tracy McAdam calls, that's a thick problem.
Thick?
A thick problem. So that there's layers to that. It's complex. It's not an overnight solution. We're trying to have a conversation about thick problems with thin solutions. I'll pay you differently. I'll give you $100 per month to do differently, but I want better outcomes and I want, lower costs. By virtue of, the whole idea was, over the last decade, the reason to invest in primary care is because we'll do site of care switching. We're going to drain your ERs and some of your hospital admissions because they're preventable, and that preventable admission will pay for the investment in primary care. Well, that's the truth of the matter is that to do that takes at least 5 years, except in high risk, kind of hotspotting groups. And even then, you have to invest a lot in primary care to get a lot. So there's probably a cost neutral investment. The real gains that we see in systems like NUCA, Kaiser Permanente, parts of IHS, where you invest in primary care over a decade, you get the kind of population level and fiscal impacts. If you look at the countries in Europe, if you look at middle income countries like Costa Rica, we've done a lot of work in Costa Rica at Ariadne, really working with them to understand, how does this little country of, barely 5 million people, that spends about $950 per person per year on healthcare. We spend about 13,500. It's just the price has gone up this year. And they have a higher life expectancy, better chronic disease outcomes, better preventive care. And so how are they doing it? And the answer is that they're doing it because they went through this decision process 30 years ago. 30 years ago, where they said, we can invest our budgets in either building hospitals in big cities in acute care and better specialty care, or we can essentially build out teams where each team, doctor, nurse, pharmacists, and a couple of community health workers, is responsible for about 5,000 people. Okay. They're going to see every family, either at their home or in the clinic every year. They're going to collect information on their healthcare needs and their social care needs. They're going to integrate it into a central record. They're going to do proactive outreach. They're going to do acute care follow-up. And they're going to take care of all of that in an information system that works, and they're going to integrate public health and medical care functions into these teams. And what happens? Those kind of outcomes for 10% of our costs per year. Is Costa Rica replicable tomorrow? No, but there are aspects of Costa Rica that you see in the highest performing systems in the US that we would do well to ask questions on how we flip the questions.
Yeah, it reminds me, I had a conversation with a CMO of a large system at the time, and I was an employee or a leader in the system at the time, and I had a very similar conversation. I was talking about Haiti and Paul Farmer, and I think I used the country of Chad as an example of some of these care team models. And I think I actually said Uganda. Yeah. And he's like, are you kidding me that we're using Uganda to compare it to our healthcare system? And I said, absolutely.
We should absolutely. And Rwanda and
we have to flatten that hubris right now if we're going to actually really make inroads in this
again,
space.
We've had, the current system hasn't always existed. It's really about a 30-year development to get us where we are in the US. I mean, 30 years ago, dermatologists and internists made roughly the same amount of money. Cardiologists and internists. It's been the evolution over time, over the last 30 to 40 years of this system. So we can't expect it to turn around, instantly. But we also can't expect it to change unless we start changing things now.
Is healthcare I don't know the right language to use. Is it a self-created problem, or are we in healthcare a symptom of the broader societal, maybe our whole society is being financialized and we are just a byproduct.
I think that we all are products of the complex social and ecological systems that we're in. But, when I talk to healthcare executives, when I talk to healthcare teams, government folks, et cetera, the failures in healthcare, the failures in leadership in healthcare, to be frank and direct, are the failures to imagine that it could be different. They are the reflex towards cynicism. Yeah. They are the financialization of healthcare, but the financialization of healthcare onto short-term, low horizon, near-term horizon, where again, the cynical take is that nothing can change because it never changed, even though, as Bruce said, actually all this stuff, if you look at under the hood, is idiosyncratic, fairly recent, totally changeable with a combination of political will, redistribution, and some sacrifice. And I'm not saying political will on the political spectrum. I'm saying actually here's where there can actually be bipartisan consensus. No side of the political aisle wants to keep paying a lot more for crap. Mm-hmm. The patients who make up the voting electorate are being asked to pay more and more out of pocket for impersonal, unsafe, overly expensive systems that aren't meeting their needs. That's a political liability wherever you sit on the aisle. But the more important thing is I am very impatient, and I strongly push back with facts, not emotion, to healthcare leaders who presume to believe the conventional wisdom that they're actually asking the right questions. Or even worse, to sort of say that they come to these conferences and everybody, drinks from the cup that runneth over of value-based care, and they say nice things about the slow and transition from volume to value, and then do nothing about it because they are afraid to provide the fiscal, moral, and healthcare leadership that might cost them their jobs, yes, but that would actually transform the system, because we know what we need to do. It just takes a lot of courage to do it. It's about creating a system that's not just about running up the technical, the procedural, and the capture of all these expensive procedures and hospitalization. We have, and we are willing as a country to spend more money than any other country. It isn't a resource question. It's a question of, are we willing to tell huge parts of the system, the 35% that Berwick and others have said don't really contribute to the bottom line? Are we willing to sort of say, you are going to get less? We don't care if you squeak and squawk. You are going to get less because you're not adding to the bottom line. We are going to invest enough, but not more than we need in our acute, procedural, and technical parts of our healthcare system. And we are not going to look at the geriatrics, primary care, pediatrics part of our system as an also-ran kind of charity case, basket case. Yeah. We're going to say it needs to be doubled in 5 years, from 5% spend to 10% spend. Okay. If we double that 5 to 10%, we can get the investments in the best part of our primary healthcare system, which are community health centers. They can care right now, they care for 10%. They could care for 20% of the population and get great outcomes amongst the poorest parts of our communities. And we could create a primary care system that, instead of only retaining 20% of its postgraduates, it can retain 40%, because they see a job that they want to do that's attuned with their values, that they go into medical and nursing school to do, and they see that it's doable.
So make this very tactical for you, right? So put yourself in the shoes of a green visor wearing Kansas hospital CFO.
Yeah.
No, let's not do Kansas, because they're not Medicaid expansion, so they're getting a bonus out of this administration.
Yeah.
So not a bad example.
Okay.
Let's take a Medicaid expansion, Missouri. Okay, let's take Missouri.
Yeah.
You're in a rural hospital in Missouri. You've got 340B cuts in the millions. You've got work eligibility requirements. Your uninsured is going to go way up. Mm-hmm. So let's say you're facing a $5 to $10 million gap. You have to close in your budget for December 31. What is Asaf, the CFO, doing right now to ready the hospital and the care delivery system for that?
The CFO is the wrong person to ask to solve the problem.
Okay, I like that answer.
It's the question is with Medicaid. The question is with the commercial payers and with Medicare and the state.
But they're the ones going to walk into the primary care office at 4 p.m. and saying, you're 7 days behind your charting.
Right.
So, and they have to say, the question they may want to ask themselves is, what's it going to take to keep the primary care workforce we've got? And where can I get a recruiting advantage to bring more primary care in, whether it's docs, NPs, PAs, into our system? And is it going to be by increasing the salary by 10 or 20%?
Probably not an option.
Probably not an option, and probably not going to make the difference, right? You've been there.
Or if it was the option, you're going to ask them to see more patients.
Right.
I'm hearing you say will exacerbate the issue.
So are they willing to take a gamble on saying, we're going to shift from a 15-minute visit
to a 30.
We're going to go to a 30 or a 20, 40, 60 from a 15, 45. Okay. Take it a little bit at a time.
Hire some NPs and PAs to see if we can make this tenable.
We're going to look at our compensation strategies and start to say, one of the realities, even as we've moved bits of the system into population-based, value-based care, is that final mile. How are we compensating clinicians? We're doing it based on RVUs. We're going to change the way we compensate.
Yeah.
We're going to increase the percentage of compensation that is based on the panel size, and decrease the importance of throughput.
Yes.
So the changes like that, and asking yourself, will that bring more folks in? Because if you can build more capacity in primary care, you can do more in primary care.
You're asking the right question, perhaps.
I don't hear that very often.
Yes, the right question of the wrong people. Because you're right. If you said that she's sitting there as the CFO with this reality that so many of your listeners or so many of you see, so the question first is, why do we hold up, hospital C-suite leaders as being responsible and being the solution avatars for the entire country? the problem with healthcare starts but doesn't end with payment. You have to change the way that money flows, that money is structured, before you can ask the person in the middle level, which I know we're supposed to think of hospital execs as the highest level, but you're already nearly checkmated in that scenario. I'm not going to give you a try to answer.
That's exactly.
So I'm saying we need to not play the end game on that move. We need to reorient and give you some degrees of freedom.
Yeah.
Where you're not down both rooks and a bishop. I need to give you some bishops back. And that requires that we rewound the game, and you didn't make some moves that you did. And that rewinding starts then with Medicare, Medicaid, and the payers, including the employers that are in conduit with the commercial payers, to sort of say, what are you buying? What do you think you're buying? You have a chronic disease crisis. You're sick of buying crap healthcare that's expensive. So why are you paying 95% into the part that you're that's most expensive, and thinking that you're going to get anything different? Why are you mostly still paying it fee for service? Why are you paying for stuff that doesn't work? Salvage chemo and new PET scanners and then sort of saying that things like good geriatrics care, good palliative care, good primary care, good pediatrics, which makes no money. It's a lost leader. Why aren't you investing in that? So Medicaid, you take care in a kid's lifespan, you take care of about 50% of the kids at some point in their childhood in this country. You mean to tell me that you really think that you can pay for those crumbs to take care of our kids? Medicare is willing to just hemorrhage money in certain acute care cases, but then give laughable small amounts of money to rural hospitals or to primary care. Invest in different ways of paying. And I'm not saying just value-based care. Invest in hospital at home. Invest in ways of reframing. We just finished an RCT, a randomized controlled trial, on applying the urban home hospital models to super rural areas.
What's the result?
Well, it's going to come out, but I'm telling you about it now because it probably has some very interesting findings that are coming out soon. So rural community hospitals can do this without totally depressing their census counts. They need, the point being, my long-winded way of explaining is I need to give you some rooks and some couple pawns and maybe your knight back to have a fair fight here. You need to give those pawns and knights back to primary care to have a fair fight. And so the person who you're giving back from, well, they might be a procedural subspecialist or a very wealthy hospital in a big city that, might not be super happy with that, but that's what it's going to take.
I 100% agree that hospital leaders are middlemen, but I can tell you that it doesn't feel that way when the community is hammering you.
Yeah.
When to every primary care doc in the nation, the hospital president is the root of all evil, right? In my experience. And partly well-deserved, right? But partly it's because the relationship hasn't been built. The vernacular is not the same. I actually really agree with what you're saying. And without going into my story, like, what if we change that leverage point to what would it take to retain you?
Yeah.
And use retention as the recruiting tool. Because if I can keep Dr. Bruce, then Dr. Bruce probably has a few friends that would want to come hang out with him.
Yeah.
And you're right, that I will say that's one of the most powerful tools that I have found in middle America is that right.
And part of it is like from the quality, and you said this earlier, Bruce, from the perspective of what do we know from good learning health systems, what does a really good leader do? She, when faced with a crisis, goes out and talks to a bunch of people.
Yeah.
She goes and talks to her primary care workforce and says, like, what's the matter here? What's the problem? What game are you playing? What problem are you trying to solve for? Not what can I sit here in my office and dream up?
There is a common assumption that these overpaid primary care doctors are lazy, right? There is an assumption that is pervasive.
Money, they're going to play golf on the weekends,
And there's
on Wednesdays.
Yeah.
And there's also this very challenging stigma among especially family medicine, but a little bit with internal medicine, that it's not the cream of the crop. And yet you've got the Bruces, you've got the Paul Farmers, you've got the humanitarian and And that world and beyond that has choosing that specialty.
Do you know who doesn't believe that fallacy?
Who doesn't?
Patients.
True. That's a really good point.
They come in and they're
Many of them don't know their specialties. There's a doctor, and that's
well, and they're looking for someone to be on their side.
Yeah.
And who's going to be there with them? Asaf, you used the term accompaniment.
Yeah.
They're looking for that.
Wait, wasn't
from
that Paul
us.
Farmer's term for his?
Totally Paul Farmer.
Yeah.
Paul
French
used to
word.
say when I'd round with him in the hospital that, I may be an infectious disease doc, but actually I'm a primary care doc.
Yeah.
So.
Yeah. And so they know what they're looking for. And that.
And you're saying they're looking for a relationship.
They're looking for a relationship in which, and it's a relationship of mutuality. It's a relationship in which each person brings something. And what we can bring on a clinical side, we have power, right? We have the power of the knowledge we have. That's not a power, though, that's not a power to use. That's a power to put at the service of the patient in front of us.
Yeah.
And that's what they're looking for. They're looking for somebody who has some power. And in our case, the power is knowledge. The power is access to the tools of the system. And they're looking for someone who's going to bring that to them. And that requires that we know who they are, that we know what's important to them.
Okay.
Yeah.
And then that builds a sense of trust. Guess what? When you have trust, by the way, you have better utilization, right?
I just learned the other day that mistrust is one of the unwritten social determinants of health.
Yeah.
Totally.
And it drives waste, it drives excess utilization. It's what drives people to say, maybe I need one more test because I don't know if somebody really knows what's going on with me.
Yeah.
When you operate in a primary care relationship out of trust, and it takes some time, but you can build, it's remarkable how generous folks are in giving you trust.
And think about the societal goals that healthcare system planners, that business executives, community leaders, patients themselves want. They want help addressing the chronic disease crisis. They want help with substance abuse treatment. They want help with vaccine information. Who are in any study on trust at the top two kind of positions are primary care physicians and other clinicians. They are the people who patients are going to, and I see this in my practice all the time. I have many people who are vaccine hesitant, many people from all over the political spectrum. Should I do this? And do they always listen? No. But can they have a conversation to be brokered in a way that they feel seen? And does that often help them make a decision that's more tuned with what they want to do, that's good for their health? Yes. And that's this, we started the conversation about hard and soft skills. And the funny thing about all those hard skills, again, zap my heart really well when it needs to be zapped. I want you to be the best at it. But most of the time, it's not about heart zapping. It's about helping a person make an incremental change a little bit better today, tomorrow, the next day, that'll keep them out of the EP suite. And who does that? A person in primary care who can broker a longitudinal, trusted relationship. They're related, like right down the street, there's a famous bar called Cheers, right? And what's the old tagline? Where everyone knows your name. People want to go where they know. Now, they want to know.
Why don't we make that Mass General's motto?
That would be a great question
would
for the
happen if
Mass
it was?
General leaders, Mass General Brigham leaders. And in fact, one might say after their recent vote of the primary care docs to unionize, I don't think it was an accident that in the midst of that discussion came an announcement of a 5-year, $400 million investment in primary care.
Okay. I'm going to pivot to establishing your credibility. I should have known at the beginning. I'm going to pivot to that now as we wrap up. So, Dr. Asaf Bitton, Executive Director of Ariadne Labs. Tell me, what were the emotional and economic scenario of your childhood, of your dinner table? Tell me about who you are. Let me make it that one again.
Yeah.
What were the emotional and economic conditions of the home that you grew up in? And how did that shape who you are today?
Well, I grew up across cultures and across countries and states. So I was born in a small farming community. It's called a kibbutz in southern Israel, of pretty modest means, and kibbutz where sort of everything was sort of shared communally in a very desert community. My mother's American. My dad is originally Moroccan Israeli, and so my life was a series of conversations across cultures and languages. I came to the US as a kid, moved to Texas, and then to Minnesota. I think I would call the conversations at the dinner table sort of bi or trilingual conversations across cultures, across communities, across continents. And I guess the extent to which that impacts and informs my work today, I have a particular interest and affinity to try to hear people's stories and try to understand their journeys, especially people who've moved a lot and come from a lot of different cultures. Because I know the feeling of being a kid in a classroom where English was my second language, being totally unaware of what these people were babbling. I know sort of, the feeling of being an immigrant to the country and sort of my experience as an immigrant, and the feeling of really understanding that there are multiple ways of looking at the world. There are multiple truths that can be true at the same time.
Two things that we can hold in tension, opposing ideas. You're a public figure. You've been with CMMI. Yeah, you're friends with some of the more prominent voices in American healthcare. I imagine you've developed a mask over time and a script. If you were to pull that down, like who are you really? What are you most concerned about, and who are you out?
Well, I have to say, and I say this honestly, I really don't feel that I have a mask or I'm putting on a performance. I mean, I see any credibility, any useful leadership that I have is deriving from a layer and a level of authenticity and directness and being able to be in conversation with people in power, with people who have no power. Many of my patients have very little agency and power in their lives, with people who I work with across the spectrum of education and seniority. Look, I get it, from my days as a camp counselor, which I would submit to you as one of the great sort of, as a teenager to be a counselor for a bunch of rascally boys and you're kind of entrusted with their lives and got to figure out this issue that I would call, or that was called to us as being on stage, that people are always watching what you do when you're in a position of leadership. And I've also learned from a lot of good leaders and perhaps leaders that I haven't found to be super skilled, that authenticity and approachability and the remembrance that maybe my primary care training teaches me is that we're all humans, that kind of look the same and act the same, when we're in an exam room, when we're, have the same bodily functions. I'm not particularly swayed or cowed by famous people or not famous people. I see a certain leveling here. So that then translates into an intention, probably imperfect, of the way that I would hope I come across as a leader is quite similar to the way that I would hope I come across in my house, to my kids, to my friends. You'd have to ask them as to the veracity of that inference, but that, I didn't feel, especially when I did more public work at Ariadne, that it was like time to sort of put on the cape or the mask and then take it off. I think actually showing vulnerability is really important.
What was your darkest moment in the last 3 or 4 years as a leader?
I think it's a shared moment with a lot of clinicians around. I felt, and just by virtue of having, being in public health and epidemiological circles, it was pretty clear that this COVID thing was coming. And I felt, and many of us did, so I'm not taking any particular credit. I remember days in early February of 2020, counting in our clinic takes care of about 10,000 people in Boston, counting the number of N95 masks we had. We have about 45 staff members, clinicians, etc. We had, I think I remember 42 N95s. And that was an oh bleep moment. I mean, it wasn't clear to me, like, it was clear to me that this was going to happen. And we weren't ready. And luckily we had a wonderful clinic director who managed to find us some N95s, because our clinic, of the 17 in the Brigham network, our clinic was one of the 2 that stayed open the whole time. With our sister clinic down the street. One was the respiratory clinic. It was essentially an ambulatory ER for obvious COVID cases. And we were the non-respiratory acute ambulatory ER, with lots of people with COVID and acute appendicitis and all sorts of crazy things. And that process of realizing that the storm is gathering and coming, and we have 42 N95s. We have no other real PPE. I mean, that was a shared experience across primary care in the US. And in fact, the statistics that I'm familiar with of all healthcare workers, only people in the ER and ICUs had comparable mortality rates to primary care clinicians and staff, almost certainly because of the PPE shortages and the first contact that primary care offers for so many things.
Same thing for you, Dr. Bruce Fink, also from Ariadne and a family medicine physician in Western Massachusetts. But take me to your dinner table as a child. Paint that picture for me.
Yeah, well, so my mother was a teacher, taught primary grades, and I think that was, that commitment to that group of kids every year, and I watched her in that classroom, and I knew she was caring for them the way she cared for me. I think that was a huge influence. And then I had the gift of having grandparents live with us for parts of their lives. And I think it's a real richness to live. It can be challenging, but it's a real beauty and a real richness to live with older folks and grandparents as they age.
Yeah.
Those were both sort of elements of that formed me.
When was the moment that you're like, I want to go in to be a physician? And also, why family medicine?
So relatively late for me in terms of medicine. I decided to go into medicine in a tentative way. I said, if I don't like what I'm doing, I'll go do something else afterwards. And I just actually liked it. So I stayed in it.
Okay.
And I think I always knew, for me, medicine was about people. And it felt like primary care was about people. I remember, this is a little later, but working in an ER and had a person come in quite ill with a very high sodium and called the nephrologist who came in. And I was young in my training, and that's high sodium I'd ever seen in someone who was alive. And I was just so amazed. And the nephrologist came in, and he was kind of bored. He'd seen it before. He did a great job, took care of that guy.
Yeah.
And I thought, I can see that. At some point, as a specialist, you're going to see what you're going to see.
Yeah.
But if it's about the numbers or about the technical aspects of care, you're hopefully going to master. You're going to get some level of mastery. If it's about the people, everybody's going to be different. It's going to be different every time. And that's what drew me into primary care, the idea that every time someone's in front of me, there's someone else, there's someone new, it's a new person to meet and a new story to hear.
What is your proudest moment in your tenured career of serving family medicine?
It's not a single moment. Anytime so I've done a lot of administrative work, and and a lot of program level work. We talked about the Innovation Center, work at IHS, leadership work. All of that's really important, and you can kind of You hope to be able to make change at scale, but it takes time. There's very few true victories, even if you're moving the ball down the field. Every time a patient walks out of a room feeling better than they walked in, even if they don't physically feel better, but they feel more at peace, more confident, they feel like they're on the right direction, that's huge. That's like an immediate jolt of reward. And that's, I think, why the focus on relationship feels so important, because some of that, what makes that patient feel better is that they have confidence in me from a technical standpoint, that I'm going to make good decisions and that I'm going to explain those decisions in a way they understand, and that we're collectively will make good decisions together, and that we'll choose a path that is good for them. But a lot of that what makes them feel better walking out of the room is all the stuff that goes around the technical piece, that the ability to communicate intent, that I'm there for them. And we're going to do what we need to do.
So if Robert F. Kennedy Jr. called you tomorrow and said, Bruce, I'm running it. The things we're trying isn't working. I'm under a lot of pressure with the biomedical community. What should I do to improve healthcare in America? What would your advice be?
Yeah. So I'm just going to say, it's not what a single person does, and there isn't a single thing to do. So we've had a really rich discussion about things that can be done, leverage points. And I think that your use of the term leverage points, I think that's right. That's a really good way to think about a system, is where can we make a difference so that we're not making, so that may be a small difference on that leverage point, but it's a huge difference in the system of care. Mm-hmm. And it's not amenable to a single decision or a single individual. It's something we all have to own and be part of. So that's not a good answer. That's not the answer to your question. Yeah. That's the best answer I can come up with.
But I wonder, and I wonder, like, if so much of what we've tried to do at Ariadne has been to sort of say, okay, there are a set of definable, important, population relevant problems in healthcare where there's a clear no-do gap, and that's no with a K. We know what should happen. The evidence is there. The consensus is there. What does happen is because of the many opportunities for failure in the healthcare system. So instead of dwell on the failures or dwell on the evidence is here, just do it. That's an old model of quality improvement. Or just pay somebody a little more to do it. That's the pay for performance model. The system change model says, why don't we create a system in which it becomes easier for most people, not for the heroes in healthcare, but for most people in healthcare who are just trying to do the right thing, take care of their patients. Let's make it easier for them to do the right thing more of the time. What would it look like to do that? So, you start with a surgical checklist that's really, yes, these are 17 things that should happen before every surgery, but it's actually masked, and it's an opportunity for teams that come together and reform and unform and reform again around really dangerous things in healthcare to have a platform for communication. And then you have something like the work that we've done in serious illness care, which is you say, gosh, there are these incredible specialists in the healthcare system called palliative care docs, and they do something magical. They walk into somebody's room and they don't even know them. They're often called at these crisis moments in time, and they help families, patients, the healthcare system make better decisions. What would it take? We can't produce enough of them, just like we can't produce enough geriatricians, but what would it take to boil down the essence of palliative care, make it a trainable, entrustable structure of communication, not a checklist, but a way of being and knowing and working? And could that actually happen? Fast forward 7 years, you cycle that, you do a lot of human-centered design, you work with patient clinicians, oncologists, et cetera, and you build an approach to approaching these serious illness crisis moments that elevates not just what matters a lot to the patient, but in a way that you can train a fellow clinician in 2 hours, elevates critical questions about, so tell me what matters most to you as you're sick right now, but also what are your hopes and fears? What are the trade-offs that you're willing to make to achieve what matters most? And how does that then inform what we do together as a respectful dyad? And fast forward that later, after randomized controlled trials that show that this approach, this training, reduces anxiety and depression by 52% at the end of people's lives with late-stage cancer, an impact that you can't get with any meds. And you sort of say, well, if we can do it for serious illness care, and now there are 300,000 clinicians trained all over the country in this model, can we then do it for something like dementia and geriatrics, where you say, so this is an answer to like, what would I tell healthcare leaders? What could you do differently? Could we reframe the conversation about this coming silver tsunami of people with dementia around who's going to take care of them? It's primary care. We don't have enough geriatricians. What can we boil down the essence of geriatrics, palliative care, and the tacit knowledge of primary care who sees most of these folks, and ask a very simple question, which is how can we make it easier in the chaos and maelstrom of primary care to approach the difficulty of the conversations around asking about cognitive status, diagnosing dementia, disclosing that diagnosis, making it clear you're on the journey with those patients, that you'll be able to offer them your accompaniment and a variety of community supports, maybe med treatments, maybe not. What would it take to reframe the conversation of dementia away from what neurologists say and more, or what neurology guidelines tell, screen and refer, and more to how do we make it easier for primary care to be primary care, to be the primary care they need to be for their patients with dementia, and how will that help us approach this coming wave of patients with it? That's the kind of work, that's the kind of reframing, often through communication and reframing the questions, as opposed to efficiency throughputs or management methods. We're giving clinicians at the front line tools to better be in relationship with their patients as they go through hard things.
Yeah. I've been really moved by this conversation. And I want to thank you, Dr. Bruce Fink, and you, Dr. Asaf Bitton, and what Ariadne Group is doing. Thank you so much for your time today. I really appreciate it.
Thank you.
Thank you.
Yeah.
Really do appreciate it. It was a really powerful conversation.
Great.